है जात धर्म क्या सभी का ख्याल रखते हो, बस लक्ष्य है सेवा, सेवा से कभी ना थकते हो। नहीं जान की परवाह, निकले हो जान बचाने को, तुम रोक ही लोगे आंधी जो है आने को। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। कैसी ये जंग है, पड़ी मौत सांसों के पीछे, बने तुम जो मसीहा, जगी जिंदगी में उम्मीदें। वहाँ वीर खड़े हैं उन सरहदों की रक्षा में, यहाँ आप डटे हैं इंडिया की सुरक्षा में। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। एमक्योर करे सलाम आपको।
A very good afternoon. I am Dr. Komal Chavan, Chairperson FOGSI Medical Disorders in Pregnancy Committee, welcomes you all to this webinar panel discussion on pregnancy with or without COVID, do's and don'ts 2.0. We all are now in the second phase of lockdown due to COVID-19 pandemic, which has swept across the nations. Indian statistics are also not good. They are rising day by day. Cases in pregnancy are increasing, and we obstetricians are concerned about our safety and safety of our patients, and we have become the frontline healthcare workers. So we have to know about these doubts. FOGSI has come up with a GCPR and also FAQs, and we are now reading about a new novel medical disorder in pregnancy, which we have not read in our textbooks. And to clear all these doubts and to share the practical aspects and the recommendations, guidelines, we have eminent, star-studded, stalwarts, panelists who are teachers and teachers of teachers from length and breadth across India. And my privilege to introduce them. So I call upon our first panelist for today, Dr. P.K. Shah, sir. Dr. P.K. Shah is professor, is a unit chief at GS Medical College, KEM Hospital, Mumbai. He's a past dean of Indian College of Medical Ultrasound, and also a past president of FOGSI, MOGS, IAG, and a past vice president, Senior Teachers Association, Sion Hospital, past chairman of Imaging Science Committee, and joint secretary of Images, and a FOGSI representative to AOFOG. I welcome you, sir. He's also the member of Safe Motherhood Committee of AOFOG. A warm welcome to you, Dr. P.K. Shah, sir.
Thank you, Komal.
President of FOGSI, MOGS, IAG. Yeah. So I also like to call upon the first lady of ICOG. This as this webinar is in association with MOGS and ICOG, I call upon Dr. Mandakini Meg. She is the current chairperson of ICOG FOGSI, International Vice President of Medical Women of India, Central Asia, Vice President AMWI, National Vice President FOGSI, Member Managing Council MOGS, and she has numerous credits, so many books. She has authored so many books. She is a representative of the government and has done lot of good work for coordinating between the our bodies, the medical bodies and government, and she is the only key in it. Welcome, madam. And madam is also recipient of MOGS Shailaja Pandit Award for Women Empowerment, Domestic Violence, Contraception and Family Welfare. Pleasure to have you, madam. Welcome, madam.
Thank you very much.
I would call upon Now we have a leading lady from South India, Dr. Jayam Kannan madam, who was a FOGSI Adolescent Committee chairperson 2013-15 and also got a Best Committee Award, Vice President of FOGSI 2018. She is the president of Free Legal Center for Women Trichy since 1992 and member of PMNH WHO since 2008, course director of certificate course in reproductive medicines, FOGSI recognized since 2012, and she has a lot of lifetime achievement awards from IMA, Tamil Nadu Medical University, Trichy Women Association, Thrummulur Society of Siddharth, Academy of Clinical Embryologists, and Best Society President's Award. And she has numerous publications to her credit. But to top of that, she has an RCOG Award of Distinguished Service Medical Medal 2018, first Indian to receive it. So that's very great, and welcome, madam.
Thank you, Kamal.
Thank you, madam. Now I call upon Dr. Sudha Prasad, madam. She is a president of Indian Fertility Society 2020-22, director Matritva Advanced IVF and Training Center, New Delhi, teaching experience of more than 34 years, president of AOGD 2016-17, former professor and IVF coordinator of Maulana Azad Medical College, vice president FOGSI 2019, and also has received the state award by government of NCT Delhi for doing materialist service in the field of healthcare in Delhi in January 2003, awarded short-term fellowship to Hungary under Indo-Hungarian Educational Exchange Program in July 2006. Welcome, madam.
Thank you, Komal.
Yeah. And I welcome our panelist from the E Zone, Dr. Ashish Kumar Mukhopadhyay, who is a principal and professor and unit chief of CSS College of Obstetrics and Gynecology, Kolkata, vice president FOGSI 2016-17, past president the Bengal OBGYN Society, and ex-chairperson Medical Education Committee, FOGSI, WHO fellow and maternal health. Welcome, Dr. Ashish Mukhopadhyay, sir.
Hi, everybody. Thank you, Komal. Thank you very much.
Yeah. And we are not with this eminent panelist, but we have a surprise, a special invited and a senior stalwart among us. And to introduce him, I will call upon Dr. Niranjan Chavan, who is a secretary of MOGS, professor and unit chief of LTMMC, LTMGH Sion Hospital, and a national coordinator for FOGSI Medical Disorders in Pregnancy Committee. Over to you, Dr. Niranjan Chavan, to welcome our special and the guest, a special guest and a stalwart and a name in himself, who is a past president of FIGO, FOGSI, MOGS, and has numerous accolades and made all Indians proud. So over to you, Dr. Niranjan Chavan.
Thank you, Dr. Komal, for introducing today's panel discussion. I find that there are more than 2,200 users who have logged in to see this galaxy of stars of FOGSI, who have come down together to guide and also to teach all of us regarding COVID. Can I have the slide of Dr. C.N. Purandare, sir? Dr. C.N. Purandare, sir, is the teacher of teachers and guru of gurus. He has got numerous degrees to his credit, and to briefly say, it is very less, but sir has always been a guide and has been spearheading FIGO, FOGSI and MOGS for more than 2 to 3 decades now. But I have to introduce him. He is the president of FIGO, president of FOGSI 2009, Dean ICOG, editor emeritus of Journal Obstetrics and Gynecological Society of India. He has got numerous lifetime awards from FOGSI, from IFS, and is presently a consultant in his own hospital at 7 Bungalows Andheri and at St. Elizabeth Hospital, BSES and Saifi Hospital. He is also honorary consultant to the Mumbai Police of Indian Armed Forces and has represented India on FIGO Executive Board. Sir, today you have taken your valuable time to be with us. It's more than enough for all the members who are seeing us. Recently, we would also get an insight from him about the ICMR guidelines, where he is spearheading that, and he will be talking and giving us briefly the outline to it later. So thank you, Dr. Komal, and all the panelists. Welcome to this wonderful panel on COVID-19. I give the mic over to you, and please go ahead with the panel. Thank you so much. Thank you, sir.
A warm welcome to all the panelists and respected CN Purandare sir. Now we begin with our panel discussion, and I would like to ask the first case to Dr. PK Shah. A 30-year-old woman presented with 8.2 weeks pregnancy. She's a Gravida 3 Para 2 living 2. She has fever since last 4 days. Ultrasound shows a live intrauterine pregnancy, and she is coming from a COVID hotspot area, and she wants an MTP. So what would be the best option for such patient? Would you like to do an MTP first, or would you like to do more investigations? And what will be the mode of treatment or the management, whether you go for a medical or a surgical? Over to you, sir.
Yeah, Komal, thank you. Let me start with statement coming from RCOG and NICE and even FOGSI that abortion care is an essential part of the healthcare for women. Why is it important? Because it is time sensitive. We all know the gestational periods at which we can do MTP. In a given situation, there are 4 things that she is G3, P2, L2, 2 living children, 8.2 weeks confirmed viable pregnancy on ultrasound, 4 days fever, and she is coming from hotspot. So first of all, I'll take detailed history, find out whether she had any history of travel abroad, whether she had any history of contact with COVID-19 positive patient, examine her with all the PPE gear that we are supposed to wear, and confirm the pregnancy and get her investigated. And obviously, I'll ask for other symptoms, whether she has cough, fever, she has cough, any cold, headache, body ache, malaise, or difficulty in breathing. Once I have confirmed pregnancy, I'll ask for basic investigations from pregnancy point of view, that is hemoglobin, blood group, VDRL, HIV, blood sugar, etc. And because she has fever, just because we are in COVID-19 situation, does not mean we should forget about other causes of fever. So I'll ask for all the investigations from pyrexia of unknown origin. Obviously, COVID-19 RT-PCR test, that is reverse transcription polymerase chain reaction test, by taking nasopharyngeal and oropharyngeal swabs. Meanwhile, I'll take opinion of an expert infectious disease personnel in this situation. We will have to wait for about 24 hours for the COVID-19 test to come, the result to come. If she is positive for COVID-19, MTP is not an emergency, though it is an essential care. I'll do proper counseling, and if my hospital is not specially available for managing COVID-19 patients, I will transfer her to a hospital which is meant only for management of COVID-19 patients after taking opinion of infectious disease personnel. She might be put in isolation because there are no other symptoms, but she is corona positive. And once she is there for 14 days, maybe she will make fit by the person treating her there, and then she can come back after being observed and treated there in isolation. If she is fit to undergo MTP, and if she is less than 9 weeks, I'll advise her medical termination by giving mifepristone 200 milligram, and after 24 to 48 hours, about 800 microgram of misoprostol. Or if she has crossed that boundary up to which we can do medical abortion, then I'll have to admit her. I'll see to it that she has all the time masks, that all proper precautions are taken as per the Ministry of Health and Family Welfare Government of India and ICMR. And then I can do a surgical termination of pregnancy, that is suction evacuation under local anesthesia or IV sedation, and try and avoid as far as possible invasive procedure. But even if anesthesia is required, the local anesthesia in the form of spinal can be used depending on the preference of anesthetist. So what is important is that while doing MTP, I have to counsel her. Obviously, I have taken the consent, but I have to counsel her for family planning because she is already having 2 living children. And accordingly, I may use either copper T, but not do tubal ligation at this point of time during COVID-19 infection. Because if something goes wrong with the patient and she may die because of COVID-19, then the whole blame will come on tubal ligation. So I will go for either mechanical contraception, OC pills, or copper T in this particular patient. Unfortunately, we do not have a detailed guideline as regards medical termination of pregnancy and family planning, and FOGSI is coming out with the same very soon. But I would like to inform you that when I was searching on 1st of April 2020, our COG and NICE guidelines have come. I'm about only RCOG and NICE guidelines. I'm not saying that this should be practiced because we have not yet accepted. Now, what are these guidelines? That they say that the medical abortion can be practiced by telemedicine, by phone call, or even video conferencing with the patient directly. Then they say that it is important to provide these services because if not, that the patient can go outside and have unsafe abortion. So these services should be continued even during COVID-19 status. What is important is that they say that there is no need of routine ultrasound. There is no need of routine blood investigations, and offer her contraception as far as possible. Then they say that analgesia can be given to this patient in the form of codeine and paracetamol. Though they have mentioned ibuprofen, I think we in India, we do not approve of use of ibuprofen in COVID positive patients. They have said at the same time that ultrasound can be carried out only under certain circumstances. Number 1, LMP is not known. Number 2, suspected ectopic pregnancy. She has symptoms of ectopic. Previous ectopic, if she has an IUCD in uterus, or if she has undergone some tubal surgery in the past. Now, they have said that as MTP is not an emergency, if the patient needs abortion, it can be deferred if she is COVID-19 positive for isolation time. Don't be in hurry to finish it off, because she may worsen. Surgical termination, as per their advice, should be done only under local anesthesia and IV sedation. And they very clearly mentioned that if approaching the legal limits of abortions, perform feticide before the limit of abortion, that is in our country 20 weeks, and manage her after the condition stabilizes and she comes back to you and she is healthy and you have enough skills and facilities available in your center to carry out it. I hope I have answered what you asked me, Komal.
Sir, you were very good. You have given an elaborate and insight about this problem because this is a very common problem which every obstetrician and gynac, even private practitioners are suffering. They are having these patients calling in and out every day for MTP, and they have so much confusion in their mind. And sir, you were very, very precise and very nicely said. And also, you have also covered the recent guidelines. So, if Dr. Purandare sir wants to add something, sir, please.
I have just one small question for Dr. Pikesha, and if we clear that, I think all the practitioners who are practicing in this country will be at ease. We are facing situation where we have asymptomatic patients. Every patient who's coming in says that I want a termination if she's asymptomatic, and by the third day she comes back with fever where you have already done whatever you want to. Your hospital is in trouble as well. So everybody is worried about all this. So should all patients be subjected to, if any surgical intervention is needed? If we are going to do with medical abortion, it's going to happen outside, they're isolated at home, that's different. But if surgical intervention is needed, there are quite a few papers which have come in that those who require surgical intervention and those who have had COVID, the risk of complications and even mortality is nearly 20% in these patients, which is huge when you are looking at all this.
Okay. Shall I answer this here?
Yes.
Yeah. Now, it is very important that ICMR has lately said that almost 80% of the patients that they have detected are asymptomatic. So from the point of view of the patient and the healthcare personnel, doctors, nursing staff, and all the workers that we have in our hospital, it is very important that we do a COVID-19 RT-PCR. Rapid tests have been stopped for the time being because according to Rajasthan, they are not accurate and they get a lot of negative patients. So I think from the point of view of safety, during COVID-19 situation that we are facing in pandemic, it would be safer to get it done after counseling the patient and taking her consent.
Okay, thank you. And audience, this is only for you. You can hear Dr. C.N. Purandare live only on this TOG webinar. And we now move on and ask the next question to Dr. Mandakini Meg, Madam. We have a 26-year-old woman who is 6 weeks pregnant, and she comes with a report ultrasound showing missed abortion. Patient also has a high fever and cough, and she's just following home isolation and is at home for 9 days. So should the patient be admitted to a designated COVID hospital? That is my first question. Can we give her the medical line of management?
Yeah.
And what complications can we expect in such patients?
So, thank you, Komal, for that question. I just want to ask you whether she is a primary, 26-year-old.
Yeah, she is a primary gravida.
Yeah. So as Dr. PK Shah has mostly, given the about the history, I like to take the again complete history. Though she has given the history, but myself I like to take complete history. Also, I like to take ultrasound report which has been showing missed abortion and the product of conceptions. What are the products and history of how many days she has already, spontaneously aborted. That is very important because she is a patient showing the fever and signs of septicemia. So we can confuse this COVID-19 symptoms also with the septic abortion. So I will like to send all the investigations, generally whatever investigations we do. Also, I like to send the COVID-19 investigation for reconfirmation, as Dr. Purandare has rightly said, because even if we are taking precautions and doing all these things, it is our responsibility as an obstetrician that we have to protect ourselves. So even if it is done, we will do it according to our, because I am treating the patient. And also, I will like to ship this patient to the hospital because the patient is having the fever. It may turn out to be a COVID-19 with the missed abortion, or it may turn out to be leading to septic abortion. So in this case, as a treatment part, I like to start with the antibiotic and other support system, and then shift her to the hospital. In the hospital, I like to share that the medical termination or medical things are more important more than the surgical, because it is according to the ICMR that 80% of the patients do expel the products of conception, which is remaining is with the misoprostol. So 800 microgram misoprostol I like to start to this patient, and also if required, and it should be given intravaginally because she will not have the oral complication of diarrhea dysentery. If required to expel more of the products, then we can repeat this after 4 hours. So this should be the line of management for this patient. Very rarely such patient may require a surgical evacuation. But if the surgical evacuation is required, then as if the report comes by the time of the COVID, if she is not, positive, in that case, of course, we are going to do with the surgical if required. And it is not required, then of course the patient will be all right. Also, if she has got COVID, then in that case, nowadays I think municipal corporation and others, we all are, seeing that they are having the designated hospital. Previously, they were not many patients who can go to the hospital as a gynec patient or MTP patient. Now the government has come up with a designated hospital where even the obstetric department, obstetric gynec department, other departments are there. So we should not worry about that, and we should go ahead with all the protections to relieve this patient of the missed abortion and complete her evacuation. Also take one more precaution of doing that. You should see if there is any ectopic pregnancy. In the beginning only you have to just confirm that, which I forgot to tell you. So I think, Komal, I have answered all the questions.
Thank you very much, madam.
Sir wants to ask me
anything.
Yes.
Yes.
Sir, Purandara sir, you want to comment on anything on this? Yeah.
I think, madam, you were very clear. Sir, if you want to add something.
She has nearly given all the information that is needed.
Yes.
Okay. Thank you, sir.
Yes. Now we ask the next question to Dr. Jayam Kannan. A 30-year-old, she's an asymptomatic, but she has come with a report showing an ectopic pregnancy and she is COVID positive. So what would be our management? Would we do expectant, medical, or what is the role of laparoscopic management, which we usually do for this ectopic patient if she becomes symptomatic? Over to you, madam.
This patient has got two she is with both feet in the graveyard. One foot is the COVID, the second foot is the ectopic. Even though it is an asymptomatic ectopic, now we have to find whether she is a pregnancy of unknown location, whether it's a pregnancy without a fetal heart, whether the pregnancy is with a fetal heart, even if she is asymptomatic. Asymptomatic can any type become symptomatic. That is one thing. Secondly, regarding the COVID positive, why did we do the COVID? Because all routine patients are yet not available to do COVID because it is available only for prescriptions in the government hospitals. In private hospitals, especially in places like Tiruchirappalli, it is yet to come. In that case, what made us do the COVID is a big question. That means she should have had some cough or anything, or as with some sort of an advantage, she should have done the COVID. With the COVID, whether she is in the stage 1 with asymptomatic COVID or with the partial symptoms of COVID with cough, or whether she is liable to go into SARI, severe respiratory infection. So with all these things, even if she is asymptomatic, even if we think that it is a pregnancy of unknown location with a beta HCG less than 2000, we have to keep her in the hospital. We have to see that a blood transfusion arrangement is available. Asymptomatic can become symptomatic. The second one is if the fetal heart is seen in an ectopic asymptomatic, automatically the patient has to have some surgical management because asymptomatic can any time, the next 1 hour can become symptomatic and she can die of the ectopic itself if not due to her SARI. So this becomes a serious concern. So medical management, yesterday night, RCOG has revised the guidelines and it has made it very clear. Laparoscopy in this sort of cases is also taken up a lot of work. So far, there is no report by anybody except from Italy management of this ectopic pregnancy 6 cases in which they have not come out with anything. Only it is accepted for publication. RCOG yesterday has made this very clear, this thing. Please think of a mini laparotomy. If you are doing an ectopic laparoscopic surgery, in those patients, we have to have the ideal corona theater which is, I don't know, probably in Mumbai you may have, in Delhi they may have, but in Chennai, still the ideal theatre is not available in the institutional setup with positive pressure ventilation, with all the laminar flow control, with the suction evacuation, probably with an ideal buffalo filter. All those things are very, very difficult. I also had a discussion with our Dr. Kurian Joseph in Chennai, who is a leading laparoscopist. And I asked him, he said, Jayam, if I am given a chance to do an ectopic in a COVID positive patient, I will always think of a mini laparotome. That is the same thing RCOG also come with. However, since I asked about the medical management, probably pregnancy of unknown location, less than 2000 beta HCG level, probably we think of a medical management, that too in the corona setup hospital only. In Tamil Nadu, all these patients have to be registered with the government. RCH number has to be obtained even for an ectopic patient. But of course, online registration can be done by the doctor herself. So we have to register with the government saying that I have a case like this and I have referred it to the COVID hospital with the blood group and other details. So arrangement of blood, arrangement of doctors, plan the problem with the team dealing with the corona and the obstetrician. The expected management may not be lasting for a longer time unless the patient has shown a pregnancy of unknown location. If you have seen a pregnancy, even if it is less than 35 mm, no fetal heart, still the medical management is questionable now. Probably management surgically is required. If the fetal heart is there, the management has to be that way. In case of corona, who is in the third stage, severe respiratory infection, patient is on ventilator, are we going to manage the ectopic or are we going to look at the medical management? Is a big question. So far, I looked into the literature, there has not been any case reported like this. Probably in that situation, the patient under observation will take little benefit by managing the medical condition, and during the medical condition, if she shows any sign of rupture, probably the 20% mortality which has been given by our expert has to be accepted along with the COVID mortality, and probably a mini laparotomy has to be thought over in that patient, because Trendelenburg position, anesthesia general, all these things are out of question in these sort of patients.
Yes. Very well said, madam. And also, thanks for sharing the recent guidelines of RCOG, which have just come yesterday. Yeah. And you have updated and given us the insight, because there are ectopic cases being COVID positive reported in many places. Even in Mumbai, we had one case, ectopic pregnancy, who turned out to be a COVID positive later. And this, by sharing all these guidelines, you have given a lot of clarity on this subject. Thank you very much, madam.
Thank you.
Yeah. So now we have with us our special guest, Dr. C.N. Purandare, sir. And sir, we want to know about the hydroxychloroquine prophylaxis in the healthcare workers. And recently you had done a nice survey with the ICMR and with FOGSI. And what is the hydroxychloroquine? Because we all are worried, as we being in forefront, the main concern, everything becomes our healthcare workers, their safety, the safety of their contacts and their family. So Dr. C.N. Purandare, sir, I want you to tell in detail for our audience what is and how the hydroxychloroquine is going to help us. Over to you, sir.
Before I go on to that, I just want to make one comment with what Jayam Khannan said, which is very valid, that today in our country, when you are talking about the anesthesia facilities in smaller places, I'm not talking about very big hospitals where facilities would be available. Laparoscopy in COVID with anesthesia, where intubation is needed, where the introduction of gas in the abdomen raises the intra-abdominal pressure. All these things complicate the COVID situation. And in these situations, it is wise to do a quick mini lap and finish the job rather than putting the patient to anesthesia risk. the procedure, you can do whatever procedure, but the anesthesia risk is so high in these patients, especially with the microcoagulation that is happening, and therefore the consolidation in the lung that is resulting eventually. It is better not to venture into doing these things on your own, and it should be done in a COVID hospital where all the isolation and all those facilities are there. And going on to the prophylaxis of HCQ, uh, it is a uncharted situation altogether. We don't know what, we've never seen COVID before. We have never seen what medication or what to do with COVID and so on. And when some of these patients were given anti-inflammatory medicine as HCQ in France and Italy, they had shown some promise while recovery because of the HCQ which was given to them. There are so many reports adverse as well at this point of time that HCQ has not given any help at all in some of the cases in UK and so on and so forth. But we are completely in a situation which is a dark situation. We have no idea whatsoever as to what is going to prevent it unless we have a vaccine, what is going to happen if we give it, we don't give it, and so on. So when I suggested sometime in early March to ICMR that since we have been giving HCQ and chloroquine to our patients to prevent malaria and have subsequently seen benefit out of it, if this is anti-inflammatory effect is going to be helpful in our patients, maybe we could try it by giving it to frontline workers only. I'm not talking about giving it to everybody in population, but those who are in frontline, to see if at all giving it helps in preventing COVID, or if they do get COVID, then the intensity is less than what normally they would encounter if they were to get COVID when they were not taking. The ICMR, after due deliberation and lot of interaction with physicians and the deans of all the various colleges and their task force, decided that it might be worthwhile giving with a rider, saying that we don't know whether it will work or not. Those who want to take it can take it. Those who don't want to take it need not take it, but that is at their risk and ideas. Now the question is that if the drug is not going to be harmful, then it is worth taking it, because if it is not going to help it, fine, so be it. But if it does help, that is definitely a positive thing as far as this is concerned. There were a lot of questions that were asked by physicians, especially cardiologists, saying that HCQ can cause cardiac arrhythmias and all these risk factors which are there. But what we are talking about is a dose which we, all of us, have taken prophylactic, whether when we went to Africa, those who came to India, the foreigners who come to India always take it as a routine to prevent malaria. And the risk of arrhythmias in a dose which is given as prophylactic, which is 800 with 400 BD on the first day, and the weekly 400 is small to cause any major event. Now we have had response after giving for the last 2-3 weeks. Most of the government hospitals and the municipal big hospitals, they were offered this, and nearly 50% of them, and sometimes more percent, have taken it as a prophylactic measure. While those in the private sector, they were told that this is useless. The physician there said, well, this will cause you arrhythmia and so on. So majority of the private hospital residents did not take the HCQ as prophylaxis. Now, subsequent to the 4 weeks, we have sent out a survey to all the people to see what were the side effects, how many got COVID, what was the response. And the for me to tell you at the moment is too premature, because I have only 8 days response available with me on the survey that has been done along with FOGSI. Nearly 50% of the people had taken the HCQ out of the 500 that we have received till now. And interestingly, none of them had any cardiac problems, no arrhythmias, no chest pain, nothing. So this particular reason for which there was a scare was there about taking the medication at the moment seems to be unfounded. I don't know, maybe as we go along, we might get a few cases which may show that they did have arrhythmia or whatever. But at the moment, we have not seen anything. Sion Hospital, for example, had 9 cases of COVID amongst all the residents. Nearly majority of them had taken the medication. Those who have taken less than 2 weeks of medication, and yet those who have had COVID are all mild cases. None of them have gone to moderate or even severe variety, which means that at least we know that it is not going to lead to death, because they are all in the mild variety. Whether it is because of HCQ or not, we don't know as yet. But when we do the entire survey, we hope to do this at 4 weeks, 8 weeks, and 12 weeks to see the duration of time that people have taken HCQ, their net result, their side effects, if anybody had COVID, what was the situation, and so on. So we hope that by 8 to 12 weeks, we will have a considerable number of people who have taken it. And currently what has happened is all the private hospitals where they had not given have now distributed tablets to everybody to say those who want to take it can take it, which means that they have realized that there is obviously there has been a benefit in the government and the municipal setup where right from the beginning the medication was given. Let's hope for the best that we get some answers to this. At the end of it, we may now come to a conclusion that HCQ was useless, and or HCQ is beneficial. Whatever way, one way or the other, we will have a clear idea. But as long as this drug has not caused any major side effects, I don't think there is any reason to worry about this medication.
Thank you so much, sir. You have given justice to this question. And this is the reason we thought we should have a global perspective too. And to add this, we have science dissemination all over India, and we have here a webinar which is scheduled on 25th of this month between 4 to 5. And we have panelists from Israel, Germany, Milan, and of course from India. So we need to see and discuss among the global part also what is happening at their end. So now going on to our panel discussion. Yes, Dr. Niranjan. Yeah.
Can I ask? Sir,
before these two questions are asked, I would like to tell you something, that there is a double-blind study which has been started in America with 500 doctors being given HCQ and 500 being given placebo, and they hope to have a result in 3 months' time as to whether it was helpful or not. So what we have done now, already 4 weeks ago, they have started at this point of time realizing that there could be beneficial effects of giving HCQ to these patients.
Yes, Mandakini Meg, madam.
Actually, sir has sensed my question. I was going to ask him why America is buying so much of hydrochlorine and are they going to use it? That was my question to sir. How the USA is buying so much HCl, in bulk, they are buying this drug.
That when it comes to giving any medication, we are always looking towards the European or American country. If today FDA says you give everything, tomorrow India, all the physicians will say, yes, fine, we should be giving it. When I suggested this, the first question that was asked to me was whether FDA has approved giving this medication as prophylaxis. And I said to them that FDA takes normally 3 to 5 years to complete studies to give you a go ahead. And that in current scenario, extraordinary circumstances sometimes require extraordinary responses, and you cannot wait for 3 to 5 years to see whether prophylactic drug is going to work or not. And within the period of 3 weeks, America has ordered so much of HCQ to be given to everybody that it is anti-inflammatory. It is not an antibiotic. It is not an antiviral medicine. It is only anti-inflammatory medication, which is preventing the consolidation of the lung. When the virus enters the lung, the anti-inflammatory prevents it. That is the only thing that is happening as far as so the exacerbation is not as bad as it should normally happen when HCQ is given.
Okay, thank you, sir. Thank you very much.
Yeah, Dr. Niranjan Chavan.
I would like to add here, 4 weeks ago, Professor Rudy in France had recommended HCQs to be given to healthcare workers, and he was ridiculed by media, and there was a lot of issues. So the French government people, the agency, they went there, and the President Macron, he was also informed about this, but a lot of literature was going around in the internet, and as Dr. C.N. Purandare said, 4 weeks ago, they started HCQ. So he went personally to meet Professor Rudy to find out about HCQ, what is that drug and what is it so about that it is helpful in such situations. So I think there are things which have been changed now, and HCQ is now mostly given to most of the healthcare workers, and it has been widely accepted, and still we are doing that survey. Sir is doing, he's spearheading that survey. And sir, we are collecting the data also from other municipal hospitals, and we have given a recommendation to the municipal commissioner to see that this survey is completed and it has been circulated to even the FOGSI members. Thank you very much, sir, for your contribution in this COVID times. Dr. Sudha wants to say something.
That ICMR, in a very short duration, accepted my proposal and said, let us go ahead and do it. And not only that, I am happy to note that within 2 days, a letter was written to the government of Maharashtra, to the Secretary of Health and to the Secretary of Medical Education to immediately implement this in the hospitals and see what happens with the prophylaxis being given. And when we decided to do the survey, and I sent them a questionnaire, ICMR went through the survey questionnaire, added a few, subtracted a few, and finally the list which was prepared the survey was started after 4 weeks, and again they have written an official letter to the government as well as to the municipal commissioner to make sure that the survey is taken by all the doctors, whether you have taken HCQ or you have not taken HCQ, so that we know it's like a balanced arm, which is not somebody who is not taken vis-a-vis somebody who is taken.
Sudha, madam.
I just want to put one controversy that today's Times of India says that the HCQ is not beneficial, and it is USA, the people are doing research on this. Of course, Dr. C.N. Purandare sir will give after the survey, the report will come. But now to be Lexis or not.
See, all the comments that have come.
This is my controversial question.
Yeah, all the comments that have come in the press, whether Times of India or anywhere, and I had a lot of talk with the cardiologists in Mumbai. I have seen Devi Shetty and Trehan coming on the screen and saying that this is all rubbish. And one of the cardiologists in Mumbai said, "You are all COVIDiots if you are going to take HCQ." So be it. I think even if we are idiots, as long as we are not damaging anybody's health, as long as we are not doing any harm to anybody, at the end of the survey we will know whether it is working or not and who is an idiot.
We will find out the results.
Yes, we find out. So now, as we have so much discussed in depth about our healthcare workers, let's now ask Dr. Ashish Mukhopadhyay, who will tell us in detail about donning and doffing of PPE, that is the personal protection equipment. Over to you, sir.
Thank you, Komal. So far what we have seen, all the three cases, and Dr. P.K. Shah, Dr. Mandakini Meg, and Dr. Jayam Kannan, all the three cases have a fair chance of resorting to surgical management. And in all surgical management today, with a suspected COVID or a positive COVID, you need to have PPE on, that is personal protective equipments on. And this is called doning. So now this doning is not new to us. We have been doing this for cases infected with HIV, cases with HBsAg, hepatitis B surface antigen, and so forth, etc. But then this COVID-19 situation is a bit different because you see, not only is the virus is so very contagious, and you need to be very, very careful, particularly during the dosing. So I would like to just discuss a few points about salient points about the doning and doping. Now, first of all, you have to decide that who is going to don. Now, in our facility, what we have found useful is an intermediate tier doctor. That means an resident, senior resident, or a resident medical officer is useful because at the same time, he can examine the patient, take the history properly, and take the surgical decision as well. Whereas if you put a junior doctor there, what happens? He waits for the opinion from the visiting surgeon or the higher tiers, and thereby he involve more senior doctors in the isolation room, which is undesirable. We would like to keep the doctors in the isolation room to a minimum. Fine. Now, before doning, one must remember that it's a big job, it's a risky job, and it has to be taken very seriously. So before that, you have to take a meal. You have to drink enough water, not too much of water, but enough water. You have to go to the washroom because for 6 to 7 hours, you're not going to do all these things. And take all precautions and all the jewelries or the rings or the watches or the purses, etc., everything out of the system. The area where doning is to be done is very, very important. It has to be separate from the isolation ward, and it is minimally equipped. That means no array of chairs and tables and equipments and furnitures, etc. Minimal, just 2 chairs might be there and a partition. Okay, that is the doning arrangement. And you wear the hospital dress before going into doning. Now, how do you do the doning? Doning is an important job because you are keeping yourself free from the contamination. And therefore, steps of doning will be, number one, that you go for the hand rub first or a washing of hands. With the proper steps, at least 6 steps of hand washing must be done. And then you wear the first pair of gloves and hand care, and then examine the coverall for any defect or deficit. Because many of the coveralls that we get may have some deficit. You have to carefully inspect now only. Otherwise, later on, you'll be in trouble. Third is examine coverall and sit on the chair. There is one chair for the donning area, but there are 2 chairs for the doffing area. I'm coming to that later. In the donning area, there is only 1 chair. You wear the coverall starting from the legs because the boot cover must be worn first because you have to sit on the chair and do that. And then you wear the cover on and you pull the chain on like this up to here. Okay, so that's the 4th step. Then next, you wear the shoe cover. After that, you wear the N95 mask. Remember, the PPE suit that we get doesn't contain N95 mask. But today, we have to use N95 mask. We cannot use a surgical mask. Some people also use N95 mask over the surgical mask. That's fair enough. But you have to have an N95 mask. Now, wear the hood on top of your head, and then wear the goggles or the shield. Face shield is much better compared to the goggles if you have that. If you don't have the shield, wear the goggles. Then you wear the second pair of gloves. The first pair of gloves is used for all these equipments wearing, and the second pair of gloves is the final pair of gloves when you go for the doning. And now you are ready for the doning. Now, can you share this thing? I have a FOGSI, that DCPR, that page, which pictorially expresses beautifully this doning and doping. So you can follow that. That is there already in the FOGSI DCPR. So if we can share that, I can this on the screen now, my screen. Can you share this screen with the audience? So this is a pictorial representation of doning, how we do that in our clinical practice. Now, after the job is done, that means you examine the patient, you take a detailed history. The initial history was not enough. You have to take a detailed, thorough history about the travel into other states and other areas. And then you have to go for the work. That means you have to examine the patient and then take a decision about the delivery, be it a vaginal delivery or be it a operative delivery. That's a cesarean section. The indication of cesarean section doesn't vary with the COVID-19 situation. and therefore you take a decision on obstetric merit only. Okay. And then what you stay with the patient. The same person who is wearing the PPE stays with the patient. He or she is supposed to conduct the delivery in the labor room, because the labor table is there in the isolation room where she has gone in. And then if she wants a cesarean section, then the patient goes into the another OT, which is specifically designated for the COVID-19 patients, or isolation OT, so-called isolation OT. Now, after the procedure is over, the patient is allowed to stay there for some time. In a vaginal delivery, we allow 2 hours to stay there. In an operative delivery, we can keep her more period of time. And then the patient moves out from the OT into the isolation room. But remember one thing, that unless and until the entire surgical team has donned into PPE, the patient is not allowed to move from isolation room into the OT. This is very, very important, because otherwise she will spread infection. Now come to the doping part. That means when your job is over, remember this is very difficult to put it on the wear-ons for more than 6 hours. So you try and minimize the time duration of wearing the donning equipments until and unless the patient comes, then you do not don. Because wearing the PPE and sitting in the emergency room, it actually after some time, you will find it intolerable, unbearable. You cannot just eat anything, drink anything, and forget about eating, drinking. You feel breathless from within. So my suggestion is what we are following in a hospital practice. When the patient is approaching the hospital, he or she, when the party gives a call to the emergency of the hospital that I am coming, so that you get additional time. If she is not being able to do that, then she has to wait in the emergency area. There's an area, separate area for waiting of the patients. Until and unless the patient, the candidate or the surgeon is completely wearing the PPE, donning is complete, she is not allowed to move from that area. And you always ensure that the patient is wearing a mask and the hand sanitizer is used freely. And then the doctor accompanies the patient to the isolation room. Now, suppose the job is over and the doping is a very difficult task. And doping has to be done very, very carefully, much more carefully than donning. So this has to be imprinted in everybody's mind that doping is a very serious job and it has to be done slowly. Now, why do we recommend this doping slowly? Because if you take it out everything in a flash, or if you take out in a snatch like this, what will happen? You are converting the viruses which are lying with you on the dress, you are converting into an aerosol. And aerosols are much more dangerous than the droplets. And therefore, it is always recommended that you take your time for doping. And there are steps of doping are also there in the FOGSI GCPR. You can follow that. I will just briefly describe that. Can I share this thing here? Screen here, so that I can show you the audience.
From your laptop, if you want.
Yeah, on the laptop.
You have to share your screen.
Yeah. This is the doping procedure, which is recommended by FOGSI GCPR.
There is a share screen, so you can share a screen.
Okay. Share screen. Yes. Yes, share screen. Okay. This is the screen that I'm going to share with you.
Yeah.
Is it coming?
No, it's not come as yet.
This is very, very important. This
upper arrow.
Yes, I have placed that. I have clicked that.
Your PPT or your Word document will be displayed. It will come.
Yeah.
Yes,
is it coming now?
Yeah, it's come.
You can make full screen.
Okay.
Yeah, this is fine.
Make it full screen.
Okay. Now, this is the doping, which is very, very important. As I said, that this doping has to be taken with utmost caution, very slowly, very gently. So what are the procedures of doping? Let's see. Now, if you can see the guidelines for FOGSI GCPR, it is noted here. You need, what are the things that you need? You need a sanitizer. You need an observer. That's very, very important. And that observer is wearing a PPE, but it is always keeping a distance from the surgeon, at least 1 meter distance, never touches the PPE of the surgeon. That is number 2 point. Number 3, you require 3 pairs of gloves. So these supplies must be ready there. You need the doormat, which is soaked in 1% sodium hypochlorite solution. You need swabs to wipe off the dirty things that have come to your this thing. And you need red bins for the disposal of this, which is biomedically stable. safe. Now, it is important to have hand hygiene after each and every step of the doping procedure. First of all, you inspect for any defect or tear on the gown by the observer. If any, clean it with the swab with the sanitizer, which is already provided to you. And the observer supplies these materials from a distance. This has to be very, 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 very important. Then you go for the hand wash. Then you sit on the dirty chair. I told you that in the doping area, there should be two chairs, one dirty chair, another is the clean chair. You sit on the dirty chair. The purpose of sitting on the dirty chair is discard the shoe cover, because otherwise you cannot discard the shoe cover without damaging yourself. Okay. Next, you disinfect the gloves with the solution sanitizer and then remove the outer gloves. And while taking out the gloves, utmost care has to be taken that whenever you touch the gloves, the outer surface may touch the outer surface, but never the inner surface. This is very, very important. There is a specific technique of opening the gloves, all the gloves under the COVID situation. If time permits, I can show you that with a pair of gloves. Then after the disinfection of the inner gloves, you go to the removal of the hood. And the hood has to be removed like this. You slide the hood backwards like this. Just holding because you're holding that. Yes, you just slide it backwards.
All of the PDF, we cannot see the lower photographs, the diagram.
Okay.
Scroll it up. The viewers want to know.
Now it is okay.
Please scroll up. No, yes, take it up. Yes, and go on explaining then. Yes, continue.
Okay. So now you take out the hood. I was showing you the hood because the hood has to be taken out in a specific manner. Okay, and then you open the chain like this. Okay, and then you take out it in one go. Remove protective clothing along with the outer gloves. So with the clothes, the outer gloves comes out. This is very, very important because otherwise you will contaminate yourself. Next is remove the goggles or the visor. Remove that. Remember, you are always wearing a gloves here, and this gloves is actually your protecting gloves, and you have sanitized these gloves. Okay. Then you do the hand after removing the visor. Then you sanitize once again. Then you remove the N95 mask. And how the N95 mask is removed, that's also very, very important. You never touch the outer surface of the N95 mask. So you go behind your ears, you lift up the lower string, and then take out the upper string, and then take it out, and then dispose it. Remember, in these situations, N95 masks cannot be reused. In other situations, like in daily use, we can reuse the N95 mask. All Indian Institute of Medical Sciences has a protocol for that. We are also following that because of scarcity of N95, but not in these situations where you have done a delivery or an MTP or in an operative intervention, etc., etc. Okay. Now, lastly, you remove the cap, the surgical cap. Then you do the hand wash once again, and then you remove the inner disposable latex gloves. So here, what did we see? We have three pairs of gloves used here. The first one is replace the outer gloves with new ones that we have seen, and that is because you want to keep yourself safe. So this is the procedure by which you do the doping. And while doing the doping, you must think about one thing, that you cannot contaminate yourself. Even after taking out the shoe cover, you must clean your shoes, the inner shoes. I mean, the shoes that you are wearing so far, you have to clean it up with the hypochlorite solution. So this is very, very important. The whole process has to be done very, very slowly, gently, taking time. There is no hurry involved here. And remember, this doping zone is separated from the isolation area, the patient zone, by a barrier which is up to the ceiling, right up to the ceiling, and not a 6-feet partition or 8-feet partition. It has to go up to the ceiling. And the doping area has got two parts. One, the clean chair, another is the dirty chair. And after doping, the candidate, the doctor, never stays in the system, goes out of the system through a different door. He doesn't come out in the same door through which he entered after toning, but he goes out through a different door in the back of the building, and he goes out. He takes a shower, and then if he desires, he comes back into the clean area. But in our hospital practice, we do not allow that. We allow him or her to go to the hostel or the residence where he can relax. But otherwise, if he wants to come back, he has to take a shower and then change everything completely. And remember, the disposal of the PPE is very, 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 very crucial, and all biomedical norms must be followed properly.
Yes.
So that's, I think,
Yes.
about a
Thank
short
you.
about
Thank you very
knowing
much,
and
Dr.
dosing.
Ashish. You have explained very well. And I also thank for this FOGSI GCPR, Dr. Alpesh Gandhi, President FOGSI, Dr. Atul Ganatra, and Parikshit Tang for making these guidelines. And we can find these images in our GCPR, very nicely explained. Now we can go ahead with a panel discussion. Hello. Yeah, you can stop
Hello.
the screen sharing first.
Okay,
Dr.
okay.
Ashish, sir, I can't see everybody. Stop the screen. Any
Stop share.
Dr. CN, sir,
Okay, I have
wants to
stopped
make
share.
any comment or anything?
So I think
Yes, sir.
explained well how to go about it, and the recommendations are very clear. It's very easy to study those, and I think everybody must follow them when they are treating any of the COVID patients.
Yes. So
Thank you, sir.
now move ahead. Dr. Sudha Prasad, madam, next question to you. A 41-year-old, she has conceived after an IVF treatment with you, and now she is 38 weeks, and you have planned an elective cesarean section. But she complains of mild cough and fever, and the fever is 101. So, what is the best option for such
Jolly.
patient? Do we delay this elective cesarean section, and how do we go about managing this patient? What investigations would you like to do?
Thank you, Komal. In this pandemic, if somebody is having the fever and the cough, everybody thinks that it is a COVID positive patient. But many times it is not possible. The patient is 41 years old, and she is a very precious pregnancy. She is a recipient of oocyte, and she has a mild cough and fever. So we would like to know first that is she having a some is she a relative which is COVID positive? If it is there, then we have to think about the COVID that she may be in this case. There is a possibility that this patient can have a simple fever and the cough. We should do the investigation. In a pregnant patient, there may be many reasons. Simple urinary tract infection can cause the fever. There may be just a flu kind of symptomatology, which is having this cold and cough. So we will investigate. We will do simple the CBC and the urine pregnancy, the urine routine microscopy and the culture. She is 38 weeks. There is no hurry to do the cesarean section, unless otherwise there is some obstetric problem that AFI is low, decreased fetal movement. If the fetal surveillance is having probably, then we have to hurry it up. Otherwise, she is 38. We can take our time, and that we will investigate this, and simultaneously we will do the COVID testing, because it has been seen that the SARS-CoV-2 virus takes 7 to 11 days to become positive. She is absolutely in acute case. So it will take one PCR test has to be done at 0 hour, and then we will do the fetal surveillance. We will see AFI, we will keep on the fetal movement. If the fetal movement is fine, the AFI is good, we will do the biophysical profile by ultrasound, and we will see the fetal movement, breathing, everything is okay. We can wait, and after 7 days, again, we will repeat the PCR for the COVID, and we will see that it is negative. Then we can plan. Dr. Ashish has said very beautifully that how to do COVID positive. We have to take care, complete prophylaxis while doing the cesarean section, and then we can take this patient for a cesarean section. But there is no hurry immediately to jump. Even we do in our cases when the patient becomes 40 weeks to give the full chance of the maturity unless otherwise there is some indication that we have to do in hurry. I think I hope that I completed your answer.
Yes, yes. Thank you very much, madam. Very nicely explained, because this is doubt of so many IVF patients who are patient at there is a panic at the patient end also, and they know that they have to deliver early, and there are repeated calls, and to counsel them is very, very important. So we move on to the next case, Dr. PK Shah sir. A 31-year-old, she's a gravida to para 1 at gestational age of 33, has developed small amount of bleeding and some pain in abdomen, and she comes in an emergency. She also gives history of fever, and patient is from the COVID affected hotspot area. So should we manage such a patient in view of preterm labor? That is the first part of question. Second is, should we give her steroids and tocolysis? And then I want also to discuss about the risk of vertical transmission, and I want comments from Dr. CN Purandare sir regarding the studies which are coming globally. Is there any risk of vertical transmission? So sir, first you can clear about these two questions about admission and giving her steroids or tocolysis.
Thank you, Kamal. First of all, 33 weeks, minimal bleeding, pain, and coming from hotspot with history of fever. I see that she takes all the precautions to prevent infecting others, like mask, etc. I'll go into the detailed history as we discussed in first case. I'll do proper examination, including general examination, pulse, blood pressure, edema, feet, urine, albumin, RS, CVS, per abdominal examination. What is the size of the uterus? Whether the uterus is relaxing and contracting or continuously contracted. What is the amount of liquor? What is the size of the fetus? Fetal heart sounds. Do a pulse film examination first to rule out placental presentation if the os is open. And after that, if the placenta is not there, if the os is dilated, I will do PV examination to confirm what is the dilatation, what is the effacement, membranes present or not. And once I have decided this is probably a case of threatened preterm labor, I'll ask for basic investigations from pregnancy point of view, investigations from fever point of view, and get COVID-19 test done, RC-PCR. All these things will take time to come. The result takes about 24 hours. Meanwhile, I'm going to take all the precautions to prevent myself from getting infected by wearing PPE suit and admitting this patient in first place. And there are two issues now in this patient. I have to rule out accidental hemorrhage by ultrasound, and I have to rule out placenta previa by doing ultrasound. And at the same time, find out what is the gestational age, amount of liquor, etc. with the help of the ultrasound in the same sitting when I examine her. Once I have diagnosed this as a threatened preterm labor, I'll admit the patient, give her symptomatic treatment, but corticosteroids, they are now questionable whether it should be given because she's 33 weeks. We all give it between 24 to 34 weeks of gestation. Because it has been shown that corticosteroids, if you give to these patients, it may flare up the infection. So each case has to be individualized by the gynecologist treating. What is the severity of infection that the patient has come to you? Whether she has involvement of the respiratory tract badly or not, you will decide. Because she is close to 33 weeks. And as per the guidelines, because the corticosteroids are not very helpful at this stage and can harm a woman with infection, I would not advocate use of corticosteroids routinely to such patients. Number one. Number two, we used to use tocolysis to buy time to give corticosteroids. When in first place you are not going to give corticosteroids, there is no question of buying time by giving tocolysis. especially beta mimetic drugs, because if she has involvement of the lungs and you give beta mimetic drugs to avoid her from going into established preterm labor, she can go into pulmonary edema and she may die. So it is contraindicated. The beta mimetic drugs are contraindicated as tocolysis in cases of threatened preterm labor. Now, it was shown that use of corticosteroids can lead to increased mortality in cases of viral infection. Though it has not been proved in COVID as yet, because it's something new for us. So we have to be very careful about use of these corticosteroids, and it has to be individualized. So beta mimetic drugs are contraindicated, and if you really want to buy some time, you can use either nifedipine or atosiban in these patients, if at all it is required. We are not going to give corticosteroids. Number 3, the vertical transmission. There is a study, Chinese study, which shows that there is no evidence of vertical transmission from mother to fetus when she is born. The viruses were not shown to be present in either amniotic fluid or cord or placenta. So there is no question of vertical transmission. But the number of patients in the study was too small for anyone to make a conclusive decision about whether there is vertical transmission or not. We need to wait for some more studies to come and give us a clear guideline and guidance in this situation. Okay? Komal cannot hear you.
You are muted. Your mic is muted.
Hello, yeah. Dr. C.N. Purandare sir, I just wanted you to put comments about this vertical transmission, because we are hearing very contradictory studies coming. Some studies from France coming that there is a risk of a single case report which showed there was a newborn baby was tested COVID positive on birth. So what are the studies? What is your take on this? Is there a role of vertical transmission, or we require more studies?
Well, currently, as it is shown, most of the countries, there is no direct vertical transmission. It is not like HIV, where babies would come out HIV positive after mother was HIV positive. So this is not something which is a common occurrence. There may be an isolated case where the newborn may have been positive, but that may have got infected after delivery. It's not necessarily that it was in the intrauterine period that it got infected. So the chances of vertical transmission happening and the fetus getting coronavirus is highly unlikely at this point of time.
Thank you very much, sir. And I want to share with you that we have almost 2,500 users who have logged in, and there are list of almost 200 questions going. Some questions are going with the flow of our panel, so we will take questions now in between, and also we'll continue our panel discussion. So now this one question interesting is from Neeta Karda, and she has asked to C.N. Purandare sir, should HCQ prophylaxis be taken by a healthcare worker if she is planning to conceive?
Now this is as is we don't know what is the role of HCQ that is happening. Planning to conceive, you can hold on to plan conceive for the next 2 months. I'm sure there is no desperate need that you have to conceive.
It's a doctor, Neeta. Yeah.
And it's more important. It's important that if you are a healthcare worker and you need to take medication, you are going to be exposed to COVID. You're going to land up with getting fever and whatever. I don't think what is a priority one has to see in those situations, that save yourself first, conception can happen 2 months later.
Yes. Thank you very much, sir. And now there is also a controversial question coming. So during LSCS, can we do a tubal ligation? If the patient is a multi-gravida having 3 children and is interested in family planning. So Dr. Mandakini, can you just throw a light on this question?
Hello, Komal. There is for ligation, there is no contraindication if we are doing it for the non-COVID patient, because she must, if you are doing it as a routine case or a elective case, then you must have taken all the precautions of doing the investigation, taking consent, and following all the national guidelines of the sterilization, which we all know. And I am going to show you this book also. This is a book of national guidelines for the sterilization. Each and every person is having this kind of book, but it is available on the website also. So this gives you all the indications for doing, female sterilization with LSCS, with first trimester MTP, so on and so forth. So one must go through this book. And second thing is, suppose there are eligibility criteria which are given in the book, that is, she should be having one live child, a living child of 1 year age at least. So that is the criteria. She should be mentally stable, and you should have taken proper consent, and counseling must be. Suppose we are doing this patient in an emergency. So in that case, if you are doubtful that she is maybe COVID positive or like that, and you are doing it in emergency. So as all my previous panelists have said, you have to take precaution. And Dr. Ashish has given very elaborate, demonstration that suppose she is having fever and other signs and symptoms of COVID, so you have to take all the precaution. I'm not going to repeat it, but there is no contraindication for doing the sterilization with LSCS as far as the guidelines are concerned.
Thank you very much, madam. Now we have a question from Dr. Reena Vani, that case handled by us with conservative management of ectopic pregnancy came COVID positive. So patient is now okay, but what next? Now what is to be done? Dr. Jayam, madam, please unmute. Yeah.
We have already done the expected management.
Yes.
Supposing the patient we have done 14 days after the expected management, the beta HCG level has dropped down to less than 20. Then probably according to what the COVID status, the viral load, the COVID treating team is going to tell us whether she has to be hospitalized or she has to be kept in the quarantine place. In Tamil Nadu, COVID positive patients are not allowed to be kept at their house. They have to be kept in the isolation place or in the hospital depending upon their clinical manifestation. So now that the patient has shown ectopic operated, the ectopic expectantly managed has become okay, then that patient requires the COVID management. Especially she is in the convalescent stage and she has to be given the adequate supports for the corona. There are a lot of arguments about this methotrexate immunosuppression, but the dose which we give is not going to give any problem to the corona. That is what it has been generally talked about and observed. If the expected management has failed and your beta HCG level is high and the patient is COVID positive, automatically we have to shift her to the corona place where a repeat ultrasound has to be done. We cannot do the ultrasound in our center once we have found that she is corona positive. She has to be taken to the center where the corona cases are being handled. There the ultrasound has to be done. Depending upon the findings in the ultrasound, we have to proceed with the further management, which we have already discussed.
Okay, thank you very much, madam. Now, next question is to Dr. Sudha Prasad. I was coming to you. You want to add something?
Yeah, I just wanted, in Delhi, there are the government hospital has turned to the COVID hospital. So when there is a symptom in the patient or they found COVID positive patient, they go there only and they have the full arrangement of the hospital, operation theater, anesthetists round the clock, who all are not going home. The hotel has been taken for these doctors who do the shift duty and they operate here. So in Delhi, such kind of arrangement has been made.
Yeah. Now, next question
Komal, I
to
have
you,
a question
Sudha
for Dr.
Prasad,
C. N.
madam.
Purandare.
Yeah.
Well, Komal,
Yes.
I have a question for Dr. C. N. Purandare.
Okay.
Okay. Can I ask?
Yes,
Yeah.
yes, sure.
Yes. Sir, just I came across this, you must have seen also, that the RCOG in the last recommendation in just 2 days ago they have talked about the vertical transmission is probable. They have exactly used this term probable. I would just like to, it's too early to comment, I know for you, but I just want your opinion, sir, on that. And secondly, from Dr. P.K. Shah, what he said, I understand betamethasone is a contraindication for tocolysis. What about nifedipine? Is there any opinion about nifedipine? That is number two. And number three, we were talking about these healthcare workers who are being pregnant and they are asking for HCQ prophylaxis. Now, I saw the Indian guideline, GOI guideline, and that there they have shown prophylaxis of the HCQ, prophylaxis by HCQ of the healthcare personnel in pregnancy. So, what is your take on this matter? And if you are the right person to talk to the appropriate people and get some feedbacks or some reinforcing data or some other things to ask, because you seem to be connected globally, sir. That is why I'm asking you these questions.
Now, to answer about the vertical transmission, today we are talking about vertical transmission happening from 36 weeks onwards to 40 weeks. Because it's only 4 weeks that we know of that the baby has delivered and which has been found negative.
Correct.
None of us know actually if somebody who is 26 weeks pregnant comes out after 14 weeks, what is going to happen. But currently in 4 weeks time at least, those who are pregnant and those who have delivered in the last 1 month during the most of the places where this was affected, the transmission has not been seen. So on that basis, it is said that there is always ifs and buts with everything. It only time will tell. Because this is something with the extraordinary circumstances. We don't even know when the affected patient has really been affected vis-a-vis the delivery time and so on and so forth. So it's only after maybe 3 or 4 months we will know what is happening as far as vertical transmission is concerned, and especially transmission happening in the first 3 months. We will not know for a long time, and that's every possibility, because when we talk about transmission happening of anything in the first 3 months, even medication having effect in the first 3 months, even if you were to take HCQ in the first 3 months, we don't know what's going to happen, because we normally suggest that nothing should be taken in the first 3 months. So this is the situation at this point of time. We have to go by what the circumstances are and how things are progressing. And to speak on a lighter vein, when you're talking about chloroquine or HCQ as a prophylaxis for malaria, how did it start? The Britishers started it by having gin and tonic, because tonic contained a lot of quinine, and that is how gin and tonic came as a prophylactic treatment for malaria. And I hope that glass which you have and drinking your cup has a little bit of tonic water which will cover you up as far as...
it's all FOGSI here.
Hey, Rakesh, you asked me one question.
So there are so many questions coming on this HCQ. The chat is overflowing, and there are so many users who are asking, and there are questions like, sir, any healthcare worker who are no more, and do we have any statistic whether they took HCQs or no? Dr. Rita Bakshi is asking. Then somebody is asking dosage and prophylaxis for pregnant women, and is there a rationale where we can give HCQ prophylaxis to our pregnant patient? Dr. Abhinya Devi. So, sir, what is your take on these questions?
So currently, I don't think prophylaxis to general population is warranted. And I mean, we don't have enough evidence to suggest that it is going to have a beneficial effect. So if you're going to give a pregnant woman HCQ, you are only giving it with hypothetical thinking that maybe it is helpful or not. But currently, there is no evidence. We don't have any evidence to suggest, when we don't even have evidence to say that HCQ will prevent or lower the course of action of coronavirus, we can't generalize and make a statement that it should be given or it should not be given. Only time will tell. But only after this survey which comes out, we will know whether it is working in the healthcare workers, where as far as reduction in the number as well as reduction in the mortality of the healthcare workers which will take place. So these are all uncharted waters. We don't know at this point of time what is going to happen. It's only something which only time is going to tell.
Yes. Thank you, sir. I have taken hydroxychloroquine prophylaxis. Dr. Niranjan Chavan will agree with me. We both are on the taking the prophylaxis daily. And you want to add on something, Dr. Niranjan Chavan?
Yeah, I would like to say
Prophylaxis
here
don't take
that
daily, it's weekly.
It's not
Sorry?
weekly.
Weekly, yes.
Weekly. No, we are
Can I
taking
say?
the. Yes, yes.
There are 30% of questions which have come are on MTP, and the next 30% are on HCQs, and the rest of the questions are for the general. So I would like to thank Dr. C.N. Purandare sir for giving us the thoughtful insight on the HCQ. I would like now to go to Dr. P.K. Shah sir. So there is one question specifically been asked to you. There are two questions actually. This is from Dr. Jyotirmay Bajana. I don't know from where she is. Good afternoon, Dr. P.K. Shah sir. I gave medical MTP kit 1 week back. Now the patient has developed fever and she is Vidal positive. Whether I have to do COVID test? If it is positive, what is next?
Okay.
Dr. P.K. Shah.
Yeah. So now number one is that you said that she gave MTP pills for medical abortion 6 days back.
Yes, sir.
Now she has got bleeding. What is it you said? Bleeding and fever.
Sir, now she has developed fever for which the typhoid has come positive, Vidal has come positive.
Okay.
Now whether we should do a COVID test on her. She has taken MTP kit 1 week back.
Okay, you can do COVID test, do other investigations for fever, treat her meanwhile symptomatically and also for typhoid. Take urgently infectious disease personnel's opinion and see whether she needs admission, because we have to examine this patient and find out whether she has got incomplete abortion, because that will need to be completed by surgical procedure. Or you can give misoprostol 800 microgram or even 400 microgram. So this patient needs to be examined, and then only you can do treatment now. If she has got fever and if she has got bleeding 6 days after she has taken the MTP pills, do testing for COVID also at the same time. Yeah.
Can I add one thing, Dr. Shah?
Yeah, please.
Can I add one thing, Niranjan?
Yes. Please raise your
See,
hand. Whoever wants to answer will come.
In this particular case, Dr. Shah, we must see the geographical location of the patient. If you go through the very new guideline released by ICMR on 20th of April, they have mentioned that in a pregnant woman coming from a geographical area which is designated as a hotspot or where containment is going on, even if the patient is asymptomatic, ICMR is now recommending a COVID test. So I think in this case, it is a mandatory if it is from the area she belongs to. If it is a hotspot area or an area where the high incidence of COVID has been reported, you must go for the COVID test. That's what I wanted to say.
Sure. Okay. Niranjan, next question.
Thank you, Dr. Ashish. The next question is to Dr. Sudha Prasad. Madam, Dr. Sudha Prasad.
Yeah.
Does BCG vaccination to the newborn is given in every hospital as early as possible, especially when COVID is rampant all over PHC to metropolitan cities alike? Dr. Rohini Sudhakar Limaye is asking this to Dr. Sudha Prasad. Does this BCG vaccination in newborn going to help?
See, this
To us.
BCG vaccination or any vaccination for these neonates has to be continued even during this pandemic of COVID. This is very much clear. The vaccination has to be done in children, whatever the scheduled has been made, number one. Number two, the BCG, this was the query that probably is a very gray area, that in India we have done very fast action, lockdown was there, but another part was that the BCG probably has not given that much of pandemic or an epidemic in our country. The cause may be BCG, but we cannot confirm it that BCG can be the prophylaxis of this COVID. We have to maintain all the prophylaxis which we have explained in this panel. It has to be maintained. That is very much important. So BCG is not going to help any child.
Thank you, Dr. Sudha. There are still many questions. There are 30, 40 questions which are still there lined up. For Dr. Ashish,
CN sir wants to add. We'll go to CN sir. He wants to comment. CN
okay. Sir. Sorry, I didn't see. I'm sorry.
Yes, sir.
Yes, Dr. CN sir.
Please.
Well, there is a lot of work which is going on to see whether BCG is useful in prevention of corona. And there are trials which are now started where they have started giving BCG vaccination to patients to population to see if that would help in prevention of COVID. Interestingly, the 500 odd replies that we have got, believe me, anyway, in India, everybody takes BCG vaccination. 85% of the people who have answered the survey have taken BCG vaccination in their life. So again, if you really go ahead and see whether HCQ or BCG or what is really preventing from ultimate result is something which is very difficult to evaluate. But the fact remains is that majority of our people are taking BCG vaccination.
Thank you, sir, for your expert comments. Dr. Sudha and then Dr. Jayam.
Now, I just want to add something that the question was asked why in our country that the COVID positive patients are less than the US. In US, the BCG is not in the vaccination schedule. So this probably may be the reason, but answer is very in a gray area. We cannot make it absolutely clear cut.
Yeah.
There is no scientific evidence to it up till now.
Yes. The next one which is coming up is the oral polio vaccine. Yesterday night, I saw the India Today where the Global Virus Network directors have been discussing about the oral polio vaccine, which is going to be beneficial in corona patients. So probably that is the next one which is going to come in the arguments, and that may take somebody to do a work. Probably if the Rotaries are having oral polio vaccines, nothing is wrong in giving 1 dose of oral polio to all the people, as a prophylaxis.
No, Dr. Kannan, can I add one thing?
Yes.
If you get an influenza vaccine in the market, I don't know whether you'll get it or not. Administer first to yourself.
Yeah, that is also going up. The second virus, the COVID positive is going to be very bad if we are in an area where pandemic for influenza.
Yeah,
I have taken the influenza in December, so maybe I have some immunity. That is also next thing. Americans are worried, whereas in Korea, the second viral load, people were able to recover. But America is worried because the second viral load is going to be accompanied with the time of influenza, and they are more worried about it. So, with the
bottom line is what Dr. C.N. Purandar has said is the bottom line, that whether it is BCG or HCQ or whatever it is, we still don't know. We are going on speculating, and maybe some of the panic reactions from the medical fraternity, that could be the case. It may be so. That
yes.
I would like to add a very important facet to all this. That when we are talking about India, comparing India to America, the number of cases that are coming up, and you say that, well, India is doing better than America and so on and so forth. I don't know whether the situation would remain same for the next 6 weeks or whatever. But if it does remain and the intensity is low, there is every possibility that among India, each and every individual suffers from some kind of flu 3 or 4 times a year. Everybody has cough, cold, and fever, and there must be some kind of a cross immunity which has been developed to this kind of virus, which has interaction with various different types of viruses, and that could be the reason also. And I mean, it's such a difficult gray area at this point of time as to what is the net action of all these things.
Hello. Sorry,
Thank you, Dr. Mandakini.
Yeah, no, I just want to add to it that we are talking about the herd immunity. You are talking BCG vaccine, you are talking influenza vaccine. So this is a collective herd immunity which is going to, I think it is already helping the Indians. So that is what is my, point into it.
Dr. C.N. Purandare, one question from Baswaraj Shivappa Hanchanale. The staff nurse is pregnant. She is 8 weeks and want COVID prophylaxis. Can she take HCQ when she is 8 weeks pregnant? She is a staff nurse.
She's already 8 weeks pregnant and she wants
hydroxychloroquine, yes.
I don't know. I right in the beginning I said that today the role of HCQ, we are trying it out, and only after the survey we'll know whether it is worth it. I don't know what effect it will have on the fetus at 8-week gestation, and to suggest something which is not an established entity would be foolish. So I think it is better not to give something which is not a confirmed medical thing till we have a definitive idea about it.
Sir, there is one immediate answer to this response from Dr. Neeta, SGPGI in Lucknow. We have seen more than 100 patients of SLE who have conceived on HCQ. We have not seen any side effects of the same for the babies.
Then give it. We have got to. Then I would say give it. Absolutely. Then there is no question about it. If you have evidence that the SLE patients have not had any problem as far as first trimester is concerned, and I have given SLE patients, those who have had repeated abortions with HCQ in order to prevent further terminations, miscarriages happening, and they have delivered normally. So if you have a large series, I think it is worthwhile even considering giving it for 8 weeks. But all this is only when we know that this is definitely a prophylactic medicine which is available for coronavirus.
Sir, after Jayam Kannan's comment, I am going to go to Dr. PK Shah, sir. It is regarding vaccination and influenza vaccine. I will come back to you. But before that, Dr. Jayam, madam, please.
I have treated about 6 patients on plaquenil, right? Pre-conceptionally down to delivery. They were all SLE patients. In an indicated patient, giving a drug is different from giving a prophylaxis. Better this 8 weeks pregnant staff nurse tell the superiors, get out of the place, go in for a holiday for about 4 weeks, until by that time we will know whether HCQ can be given, and by that time she will also cross 12 weeks. After that, she can be in a safer way. That is, as a clinician, I will recommend this way.
Yes, that is another option where she can wait at home for 4 weeks, and after 12 weeks she can resume after the organogenesis and take. That is one safe option.
Giving an indicated drug for a particular disease is different from giving a prophylaxis for a problem for which we don't know what is the cause and effect.
Thank you, Dr. Jayam, madam, very nicely answered. Dr. PK Shah, sir, there is one question by Dr. Saraswati Krishnamurthy. The question is there any contraindications for routine vaccination in pregnancy in pandemic times, like, say, influenza vaccine?
No.
Tdap.
The answer is no. You can give Tdap and even influenza vaccine like any other pregnancy, even with COVID-19 situation that we are facing. So there is no recommendation from Government of India, WHO, UNICEF, anyone as regards change of schedule for vaccination in case of COVID-19.
Leave aside the TDP and everything, what needs to be given. Even flu vaccine at the moment is recommended in the
Yeah.
first, in pregnant women, so that they don't have the side effects eventually of getting flu.
Niranjan,
Yes, sir.
Niranjan, yeah, you can give influenza vaccine anytime during pregnancy, but it would be safer to give
Doctor,
somewhere nearer end of second trimester, so that you have a window period which can be covered, and you can not only protect the fetus, but also it would be helpful. Now here the question of whether it should be given in first trimester or not, from the point of view of COVID, I don't think there is any study as yet, because this is something new that we are facing, the COVID-19 situation. But as a prophylaxis or as a treatment, whether one should give influenza vaccine or not is yet to be discovered.
Dr. Sudha, and then I go to question to Dr. Ashish.
Yeah, I just want to add here that for the influenza vaccination, I have attended one ICMR meeting, and in that it was discussed that every year the species of influenza is changing. There are lots of variation every year. So when we, of course, we recommend we give influenza vaccination, but we exactly do not know how much will be the effect, how much is the prophylaxis it gives. So every year it changes. So it was difficult to make out. There was a lots of discussion in the ICMR meeting that it was very difficult to make out which species and which virus has to be made, because there are thousands of influenza series, that which one is coming for this year. It is very, very difficult to make out.
Dr.
Thank you,
Sudha,
Doctor.
actually, world over, there are two, February and September are two months where vaccination of flu are made, and they are made as per what the current flu levels, the vaccine, the viruses that are present. And every September to February, you are supposed to use that particular vaccine, while February to September, there is a new vaccine which comes in, which you have to use it from February onwards.
Very important message and very important information passed by Dr. Sriyan sir and Dr. Sudha Prasad. There are still many questions, but I am coming back to Dr. Ashish. This is a very interesting question. I want all of you to hear. This is from Dr. Mala Basu to Dr. Ashish Mukherjee. For 2 consecutive cesarean sections in line, and they are unknown patient, is it necessary to change the PPE?
Oh, yes.
Oh my God.
Dr. Ashish, the donning and doffing.
Yeah.
It's a very important question. I believe the day hasn't come yet that the 2 cesarean sections are lined up for both COVID positive. But yes, here you have to keep your group B ready, or the set B ready before. If you prepare this kind of a cesarean section, select out which one is relatively more urgent or more important, because
Sir,
under
the
normal
question is very
circumstances.
simple, sir, the question is very simple. Whether you will wear for 2 cesarean sections the same PPE. Let us
I'll tell
be-
you, no. You cannot do that. You cannot do that. You have to change,
Yes,
and you have to
that's what
prioritize
is
the patient.
important. Isn't it?
Let's-
Dr. Jayam and Dr. Sudha, I want your comments on this.
Let the surgeon should
Also
be
Dr.
different.
Pikesha.
Not the same surgeon should do that. Surgeon should be the different. He should be ready for the next cesarean section.
Okay.
The
really-
depends on the place where the availability of 2 obstetricians is a question. If there is only one obstetrician to do the case,
Government hospital.
especially in a COVID hospital, it is difficult to have 2 senior obstetricians. Nowadays, in
Dr.
only senior obstetrician has to do the work. In that case,
I beg to differ.
it is better to change the dress and do the case. It is better to change.
No,
Very simple.
Yes,
If
sir.
you are
even if the
performing
same person,
cesarean
even if
section
the same
yourself,
person is doing,
after finishing one, do you go and change and do the second one, or you continue with the same gown and same gloves?
Question.
Obviously,
Personally, would not like to go with the same dress. I would like to change the dress, whatever be the time that is taken for all this change and this thing, doing
I think Dr. PK Shah sir is also acknowledging the same. Mandakini madam, you are raising your finger, but you are also saying the same.
yeah.
Can I move to the
Yeah, I'm
I
saying
just
the
add
same.
one thing.
It's a luxury. It's a luxury to have two surgeons nowadays. So it is
Yeah.
better to observe the precautions rather than changing the surgeon.
Yeah, and
So
I just want to
change the PP.
yeah, I wanted to add the experiences which people are sharing of doing cesarean section in PPE. It is really a very
Yeah.
tedious process. You know, a person, a physically, yeah, obstetrician will not be able to perform two cesarean section back to back. So the question
Thank
of
you.
changing
Thank
PP
you, Komal.
will not.
Thank you, Komal, for this nice input. I would like to add another thing on this. Suppose a person has to do two consecutive cesarean sections. What will happen? The point that I emphasized time and again repeatedly, that doffing will be very in a haste, in a hurry, quick, and then that is undesirable.
Yeah.
Because whenever you are doffing quickly or urgently, because you have to go to the say, next case, then you are doing it rapidly and you are making the
But
viruses in the aerosol format.
yeah, but sir,
And
I'm
it is more
telling that the same
infectious.
person will not be able to again don
No,
and doff for the next
no way,
cesarean section. There should be a
no
separate
way. It is very, very
obstetrician
tiring and
because
There has to
exhausting.
be separate
yeah, it
team.
is very
On a,
exhausting
on
and
a,
very hard.
Exhausting.
Yeah,
I
we'll
would
move
like to
ahead.
say
And also visibility is
on
a
a serious
problem.
note here, this question has come on a serious note because there is lack of PPs, and probably Dr. Mala has asked from genuinity and from a serious point of view because there is a lack of PPs, and it is a relevant question, but obviously we will not like to use the same one, and a person would not like to do next cesarean section with all these things and precautions to be taken. Now, after discussing PP for 5 minutes, there are 10 questions now which are just on PP. I'm just going to enumerate, but I'm not going to ask anyone. Please bear with me. PP is unsterile. What to do? If you are unsterile, how to maintain the sterility in the OT for cesarean section?
You should
When
not.
do you put on a sterile gown? When do you do not put an unsterile gown? How do you wash a PP before putting? And after using, whether you can reuse? I think all this has been explained in the GCPR guidelines. So it is obviously known that we are not going to use it. They are reusable. Some of them are available made up of rubber, but then they have to be ETO sterilized. You should have that facility with you. Yes, Dr. Ashish, last comment. Then we move on to the
Just
next question.
you have said it beautifully. Just I want to add one line with this, that whenever you are donning the PPE, carefully inspect the pack. If the pack is by any way torn or damaged or mutilated or whatever it is, do not use that PPE. That is the first caution that you need to do before donning. Okay, because anyway, if the packet is torn or damaged or whatever it is, do not discard that PPE. You have to do that,
Okay, there are still
and there is no
many
question.
questions. I will take one or two questions. PPE का 10 questions हो गए. Tubectomy has come again. Dr. Mandakini Meg, they don't want to leave about tubectomy. Now they are telling one lady seriously has asked Manjurati, can we do posterior colpotomy and do the tubectomy in a normal delivery?
Obsolete procedure.
Means posterior colpotomy, vaginal tubectomy she's talking about.
Vaginal route, it is very difficult.
She's
But do
talking
you do posterior colpotomy in such cases of delivery, normal delivery?
no.
Normal delivery.
No.
Why should she do?
Answer is no.
No.
We are not going to
Not
do.
way.
We are
Because
going to
she must Manju from Ujjain, I think. Manju, you must read this book and keep this book with you. This is national guidelines for the age. It is nowhere mentioned about the colpotomy. So you have to follow. Otherwise, you will be fined. If the patient goes in the legal this thing, then you will have problem. So
You
please
will-
follow these guidelines.
You will
Absolutely, there are many questions which are lined, and but unfortunately or fortunately, I would say fortunately, we are ending on with a very serious note. Though we had a lot of issues which are there, but I will still take one last question of Dr. Neeta. If a COVID positive asymptomatic primary gravida at term comes in latent phase of labor with a normal CTG, considering the amount of time required to deliver and multiple people being involved in the care, do you recommend a cesarean section on her? Last one line. Then I end. Dr. Ashish, one line.
Up until now, this is also said in the GCPR of FOGSI that all COVID positive cases have undergone cesarean section if they are eligible. If this is an indication, now you can draw your conclusion. This is the situation now. I don't know whether this situation will change tomorrow or not, but this is the situation which is lying now.
Yeah. Dr. CN.
COVID is not an indication for cesarean section. We have enough indications by now. We don't want to add one more as COVID as an indication for cesarean.
Yeah,
It is not.
that's
Dr.
true.
PK Shah.
Niranjan,
Dr. Sudha.
Niranjan, as Dr. CN very rightly said, that presence of COVID-19 infection is not an indication for C-section. Basically, only on obstetric indication one should do ideally cesarean section. But if because of COVID she has got severe respiratory distress, and to prevent her from continuing with this distress, you can have C-section and deliver the patient faster so that her problem can be alleviated by C-section. Otherwise, there is no
One line.
indication.
No indication. One line. I want one line. देश जानना चाहता है एक ही line.
Absolutely, there is no indication for cesarean section in patients who are expected to deliver normally in COVID patients
Yeah.
or non-COVID also.
There is no indication. There is no indication of doing cesarean section if the patient is not having severe respiratory problem. Severe, I'm telling, who cannot push, who cannot bear down. So in these cases, if she is such kind, then probably cesarean has to be done, otherwise not.
Cesarean section. Should I say? Should I say now?
Yes. Yes.
Cesarean section should be done only in indicated cases. So the COVID respiratory problem will come in the indications when she is not able to push and pull, because it will come in the medical indication. So no.
Thank you all of you.
No cesarean section
Thank
should
you
be done for the
wonderfully.
COVID only. Okay, done. Yeah.
Thank you all of you, madam,
Thank you,
and
Niranjan.
sir, all seniors. You have been so wonderful. As the virus permeates the United States, bringing the number of confirmed cases over 8,34,000 deaths, and there are more than 42,000 deaths which are occurring, higher than anywhere else in the world. India still is much better off as compared to them. China is also responding to new outbreaks in the country's north, taking the new epidemic prevention measures this week in an effort to stamp out a flare-up of the virus. While the numbers, this remains modest, it is a sign that the fight against the outbreak for much of the world could be a long battle one to go ahead. With this, I would like to end the session. Wonderful participation of all seniors. And thank you, Dr. Komal, to be there with us. And obviously, this would have not been possible because of the support of MCure Pharmaceuticals Limited and the Science Integra team. And I would like to thank all of you, especially Dr. C.N. Purandare, sir, to take out the special time. And sir, you were going to be here only for HCQs, but there were about 30 to 40% cases of HCQs, and you have answered so wonderfully and given a perspective of the whole world, not only about India, but HCQ has come up really well for prophylaxis. And Dr. PK Shah, sir, 30% of questions were on MTP, family planning. Dr. Mandakini, madam, and obviously, and Sudha, madam, you were so nice to answer all these
Niranjan.
questions, especially the
Niranjan.
recent guidelines
Just
which you
while
got,
we-
Dr. Jagannathan, of 21st of April. Ashish, I am going to come for donning and doffing. That is your last.
No. Not
You have
donning and
been so
doffing.
nice.
I just, before saying goodbye to everyone, I just want to share one line from our own FOGSI GCPR. Just share the screen. I mean, sharing the screen with you, and I wish everybody to read this. I wish everybody to read this. It will come, and I will show you what I am going to show. This is very, very important. Just everyone to note this and comment and then say goodbye. Is it coming on your screen?
No.
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 Sir, you have to share us.
Now, coming.
Yeah,
So I will read this for you.
it will come.
At present, this is from our own FOGSI GCPR. At present, pregnant women have almost universally been delivered by cesarean section when they present in labor with COVID-19 infection. There is no proven scientific rationale for this. It could reflect local preference and practices. This is from our FOGSI GCPR.
Very rightly.
So
said.
with that, I think I I would like to agree with you. The time has come that we can say goodbye to all of you, and thanks a lot for sharing such wonderful moments with each other.
Why
Dr. Ashish,
why
Dr. Ashish, please do that sharing.
they have been
Please
delivered
stop
by
the sharing.
section? Why is it said that they're universally being delivered by cesarean section? That is not correct. If
Correct.
you go and see in Europe, I'm giving you an example of Ireland where my son is there, Nikhil, and he's a consultant there, and he's going and delivering all vaginally. Then nobody is being delivered by cesarean section just because they are COVID positive. So this is a statement which is not absolutely true.
Yeah.
If anybody is doing cesarean sections universally for COVID-19, it's more of fear
Yeah.
or whatever than actually the obstetric practice.
We need to change that.
I agree.
Thank you
all
so
of
much.
you. I think
Okay, thank you, Niranjan, Komal, and goodbye
Thank
to all
you,
the
Niranjan and Komal,
Thank you, Niranjan.
and everyone.
Thank you.